So I'm going to switch over to muscles now in terms of the gluteal region. We have a very, very large, powerful muscle that's useful for extension at the hip, in particular extension, powerful extension of the flexed hip. So I'm going to go back to my step climb here. I'm going to use my left leg, I'm going to step up, and then I'm going to extend at my left hip. And on a good day, I'm lifting 175 pounds. On a bad day, it might be 180. That's a really powerful muscle to lift most of 180 pounds just like that. That's extension of the flex, a forceful, powerful extension of the flexed hip. And you do that when you climb steps. You do it when you sprint, full-on sprint. And other than that, when you're just walking along, gluteus maximus doesn't do much. It's pretty quiet. Over on this would be the left gluteal region over here. We've removed gluteus maximus. So you can see there's a whole bunch of muscles deep to it. This one here is called piriformis, and it's a really important muscle. It's one of a group of lateral rotators or external rotators of the hip. And to remind you, external rotation of the hip works like this. If we get a view of the feet again, this is the key, is to watch your feet. If you see my toes pointing forward, that's anatomic position. If you see my toes point to the outside, I just externally rotated up my hip. And if you see the toes point medially, I just internally rotated my hip. Okay. All that motion, that's almost 100% hip motion when I point my toes one way or the other. So piriformis is a external rotator of the hip. It would point the toes out to the side. And I don't know, yeah, okay, so I'm making another point here. I want to back up for a second and just point out that where you see piriformis here, there's a huge nerve. This is the largest nerve in the body right here. It's called the sciatic nerve. And piriformis is closely related to it. And we'll see in the next lecture how it can impact the function of the sciatic nerve. Another point to make about the gluteal region, this is a whole lot of muscle right here, which is really good if you want to inject, say, a vaccine intramuscularly. And there are a couple of different places that are popular for this, but here's one spot. And when you do an injection, an intramuscular injection in the gluteal region, you pick this quadrant, this spot up here. This is superolateral. It's up and to the outside. You want to stay away from superomedial because there are blood vessels there. You want to stay away from the inferior quadrants because there's blood vessels and there's a huge nerve down here too. You want to stay away from that. So intramuscular injections into the gluteal region go into the superolateral aspect of the gluteal region. Okay, that's a safe spot. There's piriformis labeled, and oh, I did actually. There is a bold term for this for this lecture. Here's piriformis, and here's the sciatic nerve, dropping down below, popping out from underneath piriformis and dropping down to innervate the lower limb. If you've ever heard of sciatica, it's a condition where you can get paresthesias, which is like tingling and numbness of the lower limb. It can cause pain as well. And that can happen for a couple of reasons. One of them is if piriformis is inflamed, hypertrophied, impinging on the sciatic nerve and kind of, aggravating it. Yeah, that's one way. That's one cause of sciatica. Okay, so I'm just resting on my feet normally. I'm going to go ahead and invert my right ankle, invert my right foot. And notice that the sole, the bottom of my foot, is now facing medially. That's ankle inversion. You get about, I think it's like 35, 40, maybe 45 degrees of inversion in normal range of motion. Right about there, it's starting to get painful, so I'm going to stop. And then eversion is the other way. And this is an awkward motion, and we only have about 15 degrees of it, so it doesn't look like much. But I'm going to tilt my foot so that the bottom of my foot is kind of facing laterally. That's called eversion, okay? And we don't think about these motions too much, but they are important if you're walking on unstable ground or like rough ground. So if you're walking on a trail with roots and rocks, or if you're walking on a beach and the sand is kind of scalloped and undulating, you're going to use inversion and eversion when you plant your foot to sort of counteract any irregularities in the surface that you're stepping on. You also use inversion and eversion if you're on like a skateboard or a scooter or a surfboard or on skis or snowboard, definitely on skis. So you'll use them there too. That's inversion and eversion. Okay, so we talked about the gluteal region. Now we're entering an official compartment. This is a muscle compartment bound by fascia. And this anterior compartment of the thigh has several muscles, including the quadriceps muscle. The quadriceps muscle has 4 heads, hence quadriceps. And all of those 4 heads extend the knee. One of them also crosses the hip joint, but I'm mainly concerned that you understand that the quadriceps extend the knee. And these are forceful knee extensors. If you're going to go ahead and take a penalty kick in soccer, see if I can get the ball in view here, right? You're going to do this. You're going to go ahead and there's going to be a backswing, right, where you flex at the knee, right? That would be the hamstrings in back. And then you're going to go ahead and kick the ball with an extension of the knee, and that's quadriceps. It's like the kicker's muscle. If you kick a ball, you're using quadriceps to do that. Powerful extensor of the knee. Notice that quadriceps crosses the front of the knee joint and inserts on the tibia, your shin bone. And where it inserts, there's a big bump. This is super easy to palpate on your own body. Just run your finger down below your patella, and there's a huge bump on the front of your tibia right there. That's called the tibial tuberosity. Tuberosity just means big swollen bump, right? And the reason the bump is there is because that's where quadriceps muscle attaches and where it's been pulling since you were a fetus developing, and it makes that big bump form. Osgood-Schlatter disease is something that may come up if you're talking to like a 14-year-old boy who plays soccer or girl. They often get intense pain here at the tibial tuberosity because they've been running around all day and they're kicking soccer balls. And for some reason in the teenage years, when there's a lot of growth and stuff, it gets really painful and can get inflamed. That's Osgood-Schlatter disease, pretty common. Let's move to the posterior compartment of the thigh. There we have the hamstrings. There are 3 hamstrings on each side. You don't need to know their individual names. I want you to know them collectively as the hamstrings. But whenever you hear a sportscast and a football player or whatever pulls up lame and they're clutching the back of their thigh like this, and the announcer says, "Oh, they've got a hamstring." Actually, they have 6 hamstrings, and they tore one of them probably. So the hamstrings extend at the hip and they flex at the knee. So this is a little odd. The knee joint is kind of turned around backwards compared to the upper limb where the elbow is just like the shoulder. The knee joint is turned around the other way. So we flex at the hip by bringing the thigh forward. We extend at the hip by bringing the thigh backward. But then for the knee, it's the other way around. We flex at the knee like that, right? So the leg goes backward. And then from that position, I can extend the knee and the leg goes forward when I do that. The hamstrings are going to extend at the hip and flex at the knee simultaneously, right? And so that's important for the backswing. If you're about to kick a ball, you use your hamstrings for the backswing to set up the kick. Okay? And then quadriceps performs the kick. Okay, I think that's it. That's the posterior. Oh, no, here we go. So if you pull or tear your hamstrings, this happens a lot with sprinters. So you'll see a sprinter jump out of the blocks, right? And in the first 3 steps, they're doing these really powerful launches, big extension with gluteus maximus, powerful extension at the hip and flexion of the knee simultaneously with the hamstrings. And then all of a sudden they pull up and they're clutching the back of their thigh. That's going to be a hamstring strain or a tear, okay, usually. So those are the hamstring muscles. The thigh has a 3rd muscle compartment. There's the gluteal region, and then the anterior compartment, the posterior compartment, and then there's a medial compartment of muscles on the inside of the thigh. And these are muscles that basically adduct. If I start like this and then I bring my thighs together, I'm adducting at the thighs. When would you do that? If you're riding a horse or a motorcycle, you're going to adduct your thighs to hang on. One of the practice questions concerned crossing the leg, and it occurs to me now that, well, there's more than one way to cross your leg, but what I was thinking of was sort of the simple version where I'm going to take my right leg and cross it over my left. I'm just going to do that, right? So to do that, I flex a little bit at the right hip, and then I abduct at the right hip and bring that right thigh over into the left thigh. So that's abduction at the hip, abduction of the thigh. And you have a bunch of muscles on the medial thigh that do that. The one that's indicated here is gracilis. It means slender. It's a graceful, slender little muscle. And it's a adductor of the thigh. In sports, particularly hockey is an example, or ice skating is an example. This happens a lot. You can get a groin pull or a groin strain. That's a medial thigh adductor. That's one of those muscles, or the tendinous attachment that's strained or torn. That's what's really happening when somebody talks about a groin pull. Okay, so right, and there's the little clinical indication there. Medial thigh adductors. If you injure them, that's a pull to the right. It's the common reference to that. All right, down to the leg, the anterior aspect of the leg. We see our tibia kind of peeking out here. Strapped across the front of the tibia are a group of muscles, including tibialis anterior. That's the one. It's super easy to palpate. You can find the sharp edge of the shin bone up front, tibia. And then if you go, so that's kind of medial. If you go laterally, there's soft muscle belly. And right there, that's tibialis anterior. Now, if I dorsiflex, that is, pull my foot upward like that, right? Dorsiflex, I'll feel tibialis anterior contract and bulge out. So tibialis anterior and other anterior leg muscles, they dorsiflex at the ankle. Dorsiflexion, just to demonstrate from the side, is where if I start in anatomic position with my feet flat on the ground, I dorsiflex, I kind of rock back on my heels, I pick my toes up off the ground. So that's dorsiflexion at the ankle. Okay? And that leads me to compartment syndrome. So the anterior and lateral legs in particular, lateral leg compartments, these are the ones that are really prone to compartment syndrome. But in theory, any of these muscle compartments that we've discussed, muscle compartment syndrome could occur there. And that occurs when you have a trauma. So a common example would be a fracture of the tibia due to something that struck the front of the tibia. And that fracture will lead to inflammation with swelling. Also, there could be hemorrhage. Bones are very vascular, very bloody structures. So if you get a fracture, it often bleeds a lot. And if you have hemorrhage, so the accumulation of blood, inflammation, edema, other fluids accumulating in the compartment, and the muscle compartment is bound by this tough, thick connective tissue that is unyielding and will not expand. What happens then is you get a big increase in pressure inside the compartment. Now, the increase in pressure is going to have consequences. The low pressure veins that are draining the compartment can get compressed by the increasing pressure outside them. And so now the blood that's gone into the compartment can't get out. And so now that's trapped there. And meanwhile, the arteries, they're still bringing blood in. So if you compress the veins due to hemorrhage, inflammation, edema, swelling, if you compress the veins, you decrease venous return, the blood can't get out of the compartment. That creates a positive feedback cycle with even further increases in pressure. Eventually, you can compress the arteries. So that now, at this point, the compartment is clearly there's been an injury. The compartment is very swollen. It's very painful. And if the pressure gets so high in the compartment that it compresses the arteries, well, now you've denied that compartment its blood supply. And the muscles inside the compartment are going to they're going to lose nutrients and oxygen, and that's going to create a situation that we call ischemia. Ischemia is where tissue is getting damaged due to poor perfusion, lack of oxygen, lack of nutrients. And if the ischemia goes on long enough, that results in necrosis, which is tissue and cell death. Okay, so compartment syndrome is a serious problem, and in fact, it is a 911 emergency. If you identify somebody with the features of compartment syndrome, let's say they've been struck, there's severe focal pain and tenderness on the spot where they might have fractured a bone. The muscle compartment is swollen, like visibly swollen, and they're in like 9 or 10 out of 10 pain, like really serious pain, and they can't move the muscles in that compartment. That may well be compartment syndrome, and they need surgical intervention now. So that's something I want you to understand, is that compartment syndrome is a surgical emergency. And it means a 911 phone call if that happens. Moving to the posterior leg, there's a whole bunch of muscles back here. The most famous of them is the most superficial. It's gastrocnemius. It's a two-bellied muscle that inserts on the heel bone, the calcaneus, through the calcaneal tendon. This is an interesting story. 20 years ago, this International Society of Anatomists, I forget the official name, got together and they decided we got to get rid of all these eponyms. So like the fallopian tube and the ligament of Treitz, all these structures that are named after somebody's last name. We need more informative anatomic names for these structures. And so they decided we're going to get rid of all these eponyms. The one name that they kept was Achilles tendon. It is still officially okay for an anatomist to call this tendon the Achilles tendon. And I guess that's because Achilles was like a mythological figure, wasn't necessarily like a real person, an actual person. So anyway, the anatomic term is calcaneal tendon, but everybody says Achilles tendon, and you can too. So gastrocnemius muscle and some others insert through this massive Achilles tendon onto the heel bone, and they are plantar flexors. And plantar flexion at the ankle looks like this. Basically, it's where you stand on your tiptoes. So I'm gonna stand in anatomic position. I'm gonna stand on my tiptoes, and that's plantar flexion. I'm using my gastrocnemius and a few other muscles that are pulling on the Achilles tendon to stand on tiptoes there. A really forceful plantar flexion, like in a sprint or when you're playing basketball, it often happens with an eccentric contraction where you're landing on the foot and plantar flexing at the same time, can actually tear or even rupture the Achilles tendon. And when this happens, the person lands, tries to plantar flex, you hear a loud pop. It's like a gunshot, and the person falls over in a heap, and then they can't plantar flex anymore, and they're in pain. That's a ruptured Achilles tendon. Really debilitating. It's like really hard to walk without your Achilles tendon. So that's something that can happen with this posterior leg muscles. Okay, finally, the lateral leg compartment. There's a couple of muscles, and the one that I've highlighted here is called fibularis longus. Fibularis because it's attached to the fibula. And fibularis longus is a muscle that everts. So when we talked about ankle eversion, where you turn the sole of your foot to the outside, this muscle is strapped across the outside of the ankle joint, and it's an everter of the ankle.